Mutreja. I'm one of the group leaders here in CITID, Department of Medicine. Today we have with us Dr. Mohammad Haqmal, who is an award-winning public health global expert and an ex-Chevening scholar. At the moment, he's working as a lecturer in University of London, working in global health space. He brings with him over 16 years of work experience of working in public health projects, primarily in Central Asia and in Afghanistan and Pakistan, so very much focused on the Middle Eastern territory as well. And he's previously led multi-million-dollar projects in primary healthcare, especially maternal and child health level at regional and national level. He was also a key person in setting up the district healthcare system in Afghanistan from 2008 to 2012. And he was awarded the prestigious Public Health Hero Award, which is a national award of Afghanistan given to the highest achievers in public health space in the country because of his implementation of various community healthcare innovations. And those included Afghanistan Health Village Initiative and Afghanistan $1 Project, which was quite a massive talk around the world. He's a qualified doctor, did his clinical qualification in 2003. He's also got several other qualifications that are Global Health and Development Masters and Public Health Masters from Liverpool, University of Liverpool and UCL. And then he's also done Executive MBA and Diploma in Monitoring and Evaluation. There's quite a lot to talk about him, but I think when he starts his talk, I asked him to kindly introduce himself as well. And I'll let him do most of the talking from now on. Over to you, Haqmal.
Thank you very much for the generous introductions, Dr. Ankur. And it is great pleasure to be here and to talk about these local innovations to tackle COVID-19 in South Asia. I think Dr. Ankur introduced me greatly, but I will just talk about few innovations that I have designed in the public health. As Dr. Ankur mentioned, that I'm award-winning public health expert, ex-Chevening scholar, and current lecturer at the University of City London. And I had the privilege to design, Afghanistan $1 Project, Afghanistan Healthy Village Innovations, which had significant impact on improving maternal and child health. And during the COVID-19 pandemics, I also had the contributions to design, COVID-19's eliminators, which is a kind of mobile apps. And we were using also for the COVID-19s and also iReferral, where we were also referring, patients that have been using, when we are referring patients from the communities to the health, to the clinics, and then to share also the histories, about the patients, and then to make sure that those clinics are receiving, those patients. And so this is also my contact detail. I will be happy to talk with colleagues and friends at the end, even after these meetings, if they are interested about some of the topics that I have been talking about. During my presentations, I will walk you through the following outlines. South Asia's health system capacities, public health, spendings per capita, universal health coverage status, and South Asia's global health security index, and global health, history of COVID-19's, global COVID-19's impacts, and public health interventions, WHO operation plans component, global secret for success, like in some countries are very successful. We can also mention the reasons, the secret for their success. COVID-19 in South Asia, and I will come to the South Asia's back, and different strategies, strategic difference between pre-COVID-19, COVID-19 pandemics, and post COVID-19 pandemic that we are expecting. And then in terms of public health, which kind of opportunities we are having and what are the risks and how we can convert some of those challenges to opportunities. And then I will be talking about these achievements and challenges in South Asia related to controlling COVID-19 pandemics, recommendations, innovations, what is innovations. I will be not talking, in different, in details about the innovations, but I will just bring to the audience how we were defining innovations when we were tackling, COVID-19, classification of innovations. So which group of innovation was the topics, the important area for us during the COVID-19, why innovation are needed and why it's urgently needed, when we are talking about tackling COVID-19, successful innovation, some of the important innovations in South Asia. And then at the end, I will also give, some of the messages. So what we can also get, from here, from this presentation, and then we will be also having Q&A session. So this is important, proverbs that I think when I was discussing, with people, and I at least I know in 3 languages, that's very common in Farsi, Arabic, and English, that necessity has been the mother of inventions in response to COVID-19. So it's not only during the COVID-19 pandemic, so anywhere when people have, come under the necessities, so then that necessity is putting people, to bring any kind of different kind of innovation. And so in this slide, what I will be discussing, the financial capacity or resources that we have in South Asia. So cost per capita in public health. And so Afghanistan, we have Nepal is $65. Bhutan is 105, Sri Lanka is 160, India is 75, then we have Pakistan 45. Pakistan is the country, and then we have Bangladesh, the minimum. If we can compare that one with US, Australia, Italy, in other developed countries, then you will imagine that, well, we will not be able to talk at all about the innovation and success of COVID-19, because if countries with much higher resources or had challenges, then countries with the very limited resources, even 2 or 3% of the resources compared to the rich country, how they could have done better. So resources are one of the biggest challenges in South Asia when we are talking about the COVID-19s, tackle COVID-19s. And then we also have, the second, preparedness for the COVID-19s. In terms of preparedness to tackle COVID-19s in South Asia, we had problems, and we still have a problem. So the minimum scores that we got in South Asia was around 50%. So here in the slide, you will be a little bit surprised, because there are countries which is also beyond the South Asia. We also have countries from Southeast Asia, because WHO is classifying, regions in different way. Pakistan and Afghanistan is not involved, is not included in this list, but I know both countries. So in terms of preparedness, the Global Health Security Index, Afghanistan got the lowest score in Southeast Asia, and then we also have Pakistan. Pakistan also had a kind of 50, between 50. So in terms of preparedness, we had difficulties. So this will also later help us to understand when people are not really prepared, to tackle, any kind of emergencies, especially infectious disease, and then you have limited resources. And let me talk about these access, and then this is also primary healthcare. So sorry, this is Global Health Index. So in terms of primary healthcare, we were not very good. So Afghanistan and Pakistan were not included there, but this is Global Health Security Index and Global Health Security Index. So Afghanistan is still there, is also poor. And then we have Maldives. So India was the richest one. Even the richest country had limited resources. So it was less than 50%. And then the scores that we got, it's between 35 up to 45 or 48% in those countries. So that's why the innovations in Afghanistan and South Asia was the highest because people had very limited resources. They were not prepared, but they were in a trouble. And so how to overcome some of those challenges? So they use, local context solution, different things that I will be discussing. So this was the level of preparations in terms of universal health coverage, in terms of global health security index, in terms of access to resources in public health. Hearing a kind of big sound, because with that resources we faced with COVID-19, and COVID-19 also started from China. China is also it's also in Asia. So and it also has a border with different countries in South Asia. For example, we also have borders in Afghanistan with China and Pakistan. So it means that those countries with limited resources, with low level of preparedness, and then with relatively poor coverage of universal health coverage, they face with COVID-19. And let me take you to the history. This slide is also give us very important message. So from the beginning that COVID-19 started until we develop, we have vaccines available in the market, it is less than a year, and it spread very quickly. 31st of December, China WHO announced, that WHO was alerted because of the COVID-19 cases. And initially the name was, so they thought that it's a kind of several pneumonia cases. Then we also had the first Europe case also in 7th of January, which was very quickly. 11th of January, we also had, China announced the first date. The first infected person was also, they lost their life. And then on the 2nd of February, we also had, different incidents. So deaths also inside China, and then WHO declared emergency outbreak on 30th of January. So how quickly we were moving, so the world was moving with those challenges. And then January 13th, WHO reported, that in Thailand there was a cases, and then Chinese, the guy who just reported, the case, he was died on February 7th, and then we also had, February 12th when WHO put it, the new names, they call it COVID-19, and before the name was different. And then on March 12th, the world started, companies started, registrations, to develop a vaccine. And then on December 8th, we had a market, we had a vaccine in the market. So on December 8, 2020, the UK started, the vaccine. So how quickly people were moving to develop, and this will also at the end we will discuss. There is possibility when the world is really decided, really committed to do something, they really can do it. And this slide will also give us, shape of the pneumonia of the COVID-19 also in South Asia. In Afghanistan has a border also with Iran. Iran also had the first cases after China, I think. So that's why we had many cases in Afghanistan. It started, in Afghanistan also in later January. And then we also have Bangladesh. Bangladesh also the cases were high. In Afghanistan, the reason that why the cases suddenly, went up, Afghanistan, Bangladesh, and some part of Pakistan, because the commitment, so that the action was not that much quick and strict. So those countries who took, the strict decisions to close borders and also start, community awareness, and then control, if there is 1 or 2 cases in the community, they had limited cases, the cases was not that much. For example, Nepal and Sri Lanka, so they were very significant, successful compared to other countries in the regions, because they took, strict decisions to control the spread of the virus, and then they also speed up, the testing in the country. So that's why the cases were not that much high, and they control it somehow. And also their health system was not that much under pressure, because the main principle in public health, what we were trying to do, we were trying to reduce the cases, the spread of the virus, in order to use, the existing resources also for the treatment of those patients that they were infected. So in the region, Nepal and Sri Lanka was the most successful countries, while Bangladesh and Afghanistan were also countries with the highest challenges. So here also we have, testing, because when you have, this infectious disease, the first thing is also to bring, to diagnose the peoples, and also to isolate them. So in order to isolate them, so the testing was one of these important strategies proposed by the WHO. So the WHO proposed, at least if there is one positive cases, at least between up to 10 people should be also tested there. So if you see in the country, India, Bangladesh, Pakistan, Afghanistan is not again in the list, because the score that Afghanistan got was very limited. Afghanistan was the country with the poorest testing capacity. Then Bangladesh, Pakistan. You will also see here, like Nepal and Sri Lanka, they were very good in the testing in that region. So that's why they were able, to keep, limited numbers in the country to control, the spread of the virus. But compared to other well-developed countries, so you cannot imagine, with that limited resources, so it was difficult also for them, to reach the WHO standard. So again, this is WHO's. So this slide is also giving somehow, the same sense in the first slide. So in this slide, you will also see what WHO was recommending, between 10 to 30 people should be also tested when you have one confirmed cases. But in India and Afghanistan, we were less than that one. In Nepal, it's the same. But somehow, Sri Lanka, if you see again, they had much better situation. So that's why in the regions, they were able to keep, limited, to keep control, the spread of the virus and somehow. So this is also the mortality. In terms of mortality, because we had limited resources, and in terms of universal health coverage, in terms of preparedness to fight, and then in terms of testing, so that's why in the regions we had the highest number of mortalities in the region. So 11%, the death was like 11% in the beginning. In Maldives, and then it's somehow 11s, and then in Afghanistan it was 6.5. You will also have a question in your mind that how possible that in a country that you have limited resources, in terms of preparedness was also very less, in terms of testing. So how that could be possible to keep, the lowest number of mortalities infected by the COVID-19 among the COVID-19 patients. So again, this the question, the answer would be quality of the data. So the reporting system in some part of the regions, including Pakistan and Afghanistan, so the reporting system also had a biggest problem. So that's why when we are presenting some data in global level, it is not showing a kind of association between the effort, the innovations, and also the struggle that we are doing in terms of testing and also controlling, and then the outcome. So when you see, the differences here, so it will also give us the things in terms of quality of the reporting. So reporting was not very good. So that's why in Afghanistan and also in Nepal, so we keep it showing, the lowest numbers when we are talking about the numbers. But in actual way, it was, I don't think that it's less than 11%. So again, another questions, why in our regions, apart of the resources, there are also other 3 factors that was also the reason of high mortality, because of the poor public health infrastructures, social economic, so the economic situation was low, high dense populations. And, so some of the countries, they had, the highest dense population, even I think in the Asia. So that's why these, apart from the other 3 things related to resources and also preparedness, we also have some social economic situations. So they also contributed, unfortunately, significantly to have, the highest number of mortalities in the region. Well, coming back to the WHO, so WHO in the beginning, so they also proposed social distance, mask wearings, testing, contact tracings, quarantines, and cluster investigations. And then we were talking about the vaccines, and then how to linkage, those people infected, especially in the high, when they were having, high risk factors with the health facilities. So these were the WHO's, and these have been the WHO's recommendations. In different countries in the region, they try to apply, those preventive measures with their possible, efforts. So let's, in the next slide, we will see how successful we are and which kind of innovation we apply in terms of to respect social distance, and also to see how we can also increase their testings, which kind of innovation we use for the contact tracings, and then how the quarantines was also somehow, applied. And in vaccines, we were also very fortunate, at least one country in the regions, they also had the capacity to develop the vaccines. So there was contribution in different way in terms of innovation, in terms of implications of those recommendations recommended by the WHO. Well, the sound is also giving us here different message. So this is also giving us, the different component proposed by the WHO, but that was somehow, also contextualized for some country. For example, in Afghanistan, so the country border was closed for a long time, and it's still unfortunately conflict zone. So promotion of local production was one of the local innovations that we were also working with the governments in order to see if we also somehow manage, shortage of the resources in the country. So management of the managing, the coordination. Coordination is always a biggest challenge when we are facing, with the emergency, because when you have, several partners, especially in those countries that we are discussing, they are somehow dependent on foreign aid. So many time, the foreign aid has been also spent, through different non-governmental organizations. Let me give you one example of Afghanistan. So Afghanistan, when I talk about Afghanistan here, it will also give us, sense that could be somehow applied in another country. In Afghanistan, 75% of the health budget is dependent on foreign aid. Then number of organizations, 85%, of the health services, somehow, especially public health services, are also managed by the non-governmental organization, either national or international organizations. So in some provinces, we have 2 or 3 organizations. So coordination was very important for us when we were also discussing, with those implementers. Again, with the UN organization. So UN organization also had their own role, but we were trying to make sure that, well, UNICEF is doing for what UNICEF is supposed to do. For WHO, so this also helped us a lot at the government level to understand each other organization role, and then make sure that the government also play their stewardship role, and also provide support when they need it. For risk communication, yes, we also developed different kind of messages, and we try to reach, the communities, especially hard to reach communities through different mechanisms, and we send them the messages, and at least to see if they are aware, and then they also play their role. For surveillance, we also had active surveillance and also passive surveillance. We had, like in the region, we also already had, this infrastructures when we are talking about the surveillance, and we try, to integrate, the existing surveillance with other surveillance, to minimize the risk, to use, the minimum resources, and also to achieve something about this real data. For the point of entry, so so there was some messages. In the beginning, we tried to reduce in the region, we tried to reduce the movement, from different countries. But when they were coming, so they were also giving, kind of awareness. But this is something very important that I need to talk also in point of entry. So Iran has a big border with Afghanistan. Unfortunately, Iran also pushed, at least more than 100,000, Afghan refugees that they were living in Iran, but they were pushed to return to Afghanistan. And it was very difficult time, and also for the Afghans that to receive, their own citizens from a country with the highest number of cases. So that was one of the biggest challenges, and Afghan governments tried to manage something. And again, it was with Pakistan as well. So in Pakistan, we also had many cases. In Afghanistan, were somehow Afghans are highly dependent on these medical tourism. So when they have, unfortunately, most of the health problem, they are going either to India or Pakistan. So we also try to manage somehow, those cases. National laboratories, yes. So we also have public health in private. So that's in the only regions. So in the regions, people also try, the governments also try, the health sector tries to use also the private sector as one of their strong partners. Infection prevention control, that was also somehow applied. So for the case management, we also had, hospitals, so special hospitals. So some of the hospitals was specialized for the treatment. and cooperation. So for logistic problem, we also had a problem in the whole region. So there were some example, even people, some country, they also were not able to provide, the testing facilities. So at least we somehow in the region, we apply all the component, we implemented all the component proposed by the WHO with somehow contextualizations of the regions based on the resources. So this slide is also giving us important things. As I talk in the first slide about the history of COVID-19, how quickly the world also, the shape of the world has been changed. This is just example of the schools. So you see, like 90% of the schools were closed from the beginning, from the January to 7th of April. This will also give us message also for the future pandemic. If we also face, upcoming pandemic, so the world will be again facing, similar situations, and so we need to have, preparations from the now on. So this is something that we face, and the education sector was also took the benefits, and they use, these online systems somehow based on their available capacities in the countries, at least to maintain, the school, but the school, they were not going to school. And this is, it was not only in developer, even in a country with minimum resources, they were also trying to provide, to keep, the education system somehow opens, but from one side, they moved from the campus or the building sites to the campus, to online. So, well, this is the important one. Global secret. So what was the secret for some country, for example? And I will, in this slide, I will just not talk about the issue. I will talk about some worldwide. So in New Zealand, for example, what was the reason why New Zealand also had, the capacity to, what was the reason for their strong capacity to control, the COVID-19? So the leadership also always has, the strong roles. And I'm just quoting here, the Dr. Fauci. Dr. Fauci is, the global public health hero in United States. And he was told, by the president that, well, you need to be positive and you need to take, positive attitude. Why you are always negative? Because the situation that he was seeing from the scientific ways, the situation was difficult. But when the scientists are under, the politician under the government's leadership to modify whatever he is saying, so then you cannot expect, immediate changes, positive change in that region. So that's why, unfortunately, in the US also had the biggest challenge. And it was not in US, in many other countries. Even it's not only the president, under the leadership of some Ministry of Public Health in our region also we had that problem. So that's why the government took, unfortunately, some decision to remove, ministers in the middle of the fightings when they were involved, leading, the fighting against COVID-19. I think that was also when you are changing people in the middle of the fight and bringing somebody else because of to expect, better leadership. So I think that was some justification that the related governments, brought some changes even in the leadership of the Minister of Public Health. So then we also have transparency, government transparency. So those countries that they were sharing, the real information with the community, and then they also had, the strongest trust. They built the strongest trust also with the community. They also had very successful results compared to those countries who are either, downplaying, the data or overplaying the data to use it, for their own, for their government benefit rather than, keeping, the public and trust as a top priority. Then legitimacy as well. So some country, they were not that much democratic, and then people were not having, the strong trust on them. So when the trust between community and also people were poor, this directly also affected, these result of the COVID-19 pandemic. Then planning and preparedness. So those countries that they have better preparation and they have very good result. So, but there is one important thing that I am trying to share with you. When I was reading, this Global Health Security Index report, US and UK got, the first and second position in terms of preparations. But when we were coming, if we see, the real data, so they also did not have, unfortunately, that good results and fighting with COVID-19 because they were under the influence of the three other factors that I mentioned, either leadership or I think leadership also had and brought, under the shade of some of the preparedness. And then if we if we talk about these South Korea and also Vietnam, South Korea also had positive result. The reason was because they had better preparations, and they also have had H1N1, and then there is also some other emergency that they had. So because of that, they also had better result. Well, what is the strategic differences for us between pre-COVID-19 pandemic, and post-COVID-19 pandemic? I think there is a strong result. I was just listening yesterday to the executive director of the International Monetary Fund. So she was discussing that, well, if these vaccines successfully implemented in the world, we will be able to recover back the economy. So I think this is very important, clear message now for us as a public health professional to convey. So they already had the message. They already know, the importance of public health, the importance of preparations, and also even they know about the image of the upcoming, pandemic, because we notice which kind of challenges in terms of resources and preparation we had. There is also problem in the regional level and even in the country level. And let me give you one example. When I was in fact, with our team, we were reviewing, the COVID-19 pandemic in the region and also the response. And we noticed in the middle of the fighting that, well, one country were not playing, the real role, and there were some challenges. And we just simply write a kind of letter, open letters to the media, and that was published, open letter, in fact, to the president of that country, and that was published. And you will not imagine, in the second day of these publishing the letters, so that letter was also discussed even in the cabinet meetings, and they just took some of the decisions, recommendations that we put it there. So this was the benefit somehow, the situation that we got benefit from the COVID-19. And there are several examples in the region we have. In the beginning, it was very difficult for the president, to accept, to increase, the local resources also for the public health. So the resources in the for the public health, one of the reasons that why it is very less also in the country compared to the other part of the world, because it was difficult for us to convince, the leadership of the country to increase, their local domestic resources also for the public health and also for the health sectors. Now we have better data that, well, because of the limited resources, we were not able to apply this one. And everybody expectation is from the public health now, it's getting much higher. So if expectation is higher, it means they will also somehow back and also give us some support. So the provincial support, even district support, even in the community, if you go now, they will be much carefully listening to our messages. So now, if we integrate some services under, for example, COVID-19, we will be able also to strengthen, our routine immunizations, routine vaccination for the other sectors. But this slide is just giving us a kind of clear message that the world leaders, even the leadership in different level in the world their mind has been changed, and they are ready to help us. But now depend on us which kind of strong strategy that we can propose to them to get benefit also from their intention, that their intention is somehow changed. So achievements, I will not spend a lot of time in achievements. So training was conducted, public awareness, political commitment somehow, and also to control coding, that was achieved. National response committees, regional communities, and even provincial and district community was also established. And promote innovation. So everybody was thinking about the innovation because resources were limited and there was no experience and very poor preparation that I mentioned. So everybody was trying at least to save their life, to bring some kind of innovations in their villages, how to increase the community awareness, how to pick up, those high-risk peoples that they are in the community, and procurement of related supplies in equipments. Although we had a problem, but at least the governments, the related governments, try to play their roles in the procurement of the supply and equipments, construction of the health facilities. So in some country, Even like, let me give example of China's. It was not only China that they built, biggest hospitals for the treatment of COVID-19. In other countries also in the region, South Asia regions, they also allocate enough resources, at least, to build the health facilities, to renovate some of the buildings, to make those health facilities, clinics, hospitals prepared. Social and multi-sectoral approach was also somehow, societal and multi-sectoral approach was also somehow practiced, because before, unfortunately, of COVID-19, many people were just trying, many people in the government, they thought that only Minister of Public Health is responsible for provision of services, and then they thought even in the beginning that only the Minister of Public Health will be able, to control COVID-19. But during, the fight, they noticed that, well, this is something beyond the control of the Ministry of Public Health. So that's why we also had societal and multi-sectoral approach. Challenges: limited resources, I already mentioned. Poor preparations, unfortunately, compared to other parts of the world, in most countries in the regions. Poor coordination between stakeholders, because especially United Nations, WHO, UNICEF. So there was some criticism also on their roles also in the regions, because they were also not prepared. And one of the biggest challenges that we also noticed, although the report of the global health securities index that was issued, that was released, so every country had that report, but at least nobody read that one. That's why in the beginning, first month, second month, third month, if you listen to the messages of the leadership of the country, including the Minister of Public Health, they share the message that, well, we are ready and we will try our best to control that one, without reading the report 2 or 3 years before reports, that in the reports their weaknesses was highly highlighted there, and they know that one. Relatively poor governance, so in terms of governance, because the message was not very clear all the time, unfortunately, the regions. So even the governments, they were also sharing messages. There was no constant messages. Consistency between messages in terms of preferentials in the provision of health services was not that much strong. So that's why those countries that they have very poor consistency in sharing the messages with the public, so they have more challenges. And then poor community cooperation. Unfortunately, still, if you ask some people in the region, so some of the part of the community, they will tell us, well, it's a kind of conspiracies, maybe it's not a disease, it's something, political game some people are playing. Inequity was also important challenges that we noticed. And let me give one example from Pakistan. I was reading a report. Punjab is the area where they had, the highest number of positive cases, but mortality was very high in KPK, Khyber Pakhtunkhwa, because the resources was very limited there. The area where they had many cases, they had enough resources. They were able, fortunately, to control, the situation there. So that's why they had limited number of mortality. But other province in the same country, they had very limited resources compared to that part of the country. So that's why mortality was very high in another province. Poor health system infrastructures, I already mentioned, that was covered. High density population, that was also some area where it was difficult for the community to think about the social distance, so that was and our quarantine was difficult. And when we were trying, to isolate people in the community, so for the community it was difficult, even to find, some enough spaces there, because they were living in a very high dense population. High disruption of these resources, of the services. It's known as non-COVID-19 essential services, immunization. So because of that, now we have a biggest challenge. And let me give one example from Pakistan and Afghanistan again here. Unfortunately, Afghanistan has now 48 positive polio cases, and totally number of the injection is associated, paralysis, it's 300 now. While just 1 year before, 2 or 3 months before the COVID-19, it was 29. So from 29 to 300 positive paralyzed cases, it seems that we were unfortunately not able to maintain, the operation of the other essential services. So that's why the NCD, NCD, non-communicable disease, mortality, associated mortality was very high because the other non-COVID-19 essential services was highly disrupted in the region. Even the maternal mortality and child mortality based on the UNFPA estimations will be very high, because in some area there was 50% disruption of the services. In some area there was at least 30% was the areas with a much better situation. Even 80%, we also have some examples that 80% of the non-COVID-19 essential services was also disrupted. That's why child mortality and maternal mortality will be, unfortunately, will be high. So recommendation. Science should be always respected. So that's evidence-based decisions need to be still promoted. Focus on proper distribution of vaccine. At least now we are in the stage when we talk about the vaccines, and unfortunately, country with limited resources, I hope you know the Indian company will produce enough vaccine at least to fulfill the highest priorities of the countries, highest priority needs of the country. High risk groups should be highly prioritized, So something is in paper, but in actual it will be difficult. And in our region, because of the problem in the governance, I hope the government will somehow prove to provide the essential services, like for example vaccines to those people that they are in high risk, but not the families and relatives of the politician or parliament members, which is unfortunately one of the biggest practice here. So then other important things, it's not only for the COVID-19, when we also have other services. So alternative solutions to maintain provision of the health services should be also considered one of the important things. So if provision of services is disrupted, so even we will be difficult also to track those patients that they are they are also in the high needs of the services. So innovation, what is innovation and why it's needed? Here I am also bringing two definitions. One is WHO definitions for these innovation. Another is very simple definition that we apply during fighting with COVID-19. So the first innovation is, it is new, better, more effective way of solving problem. We just apply that one. And then before COVID-19 also we had the others outbreak, and also the if we think about Ebola, during the Ebola, 17% of the resources were spent for the research. During COVID-19, only 3% of the resources were spent only for the research. So maybe there will be this will also give us a very clear message that sometime we may also apply some local context solutions rather than working, in a very broad research during the emergency. So giving more opportunities for the local problems, for the local solutions will also help us to save more lives compared to the situation when we are applying all those scientific measures during the emergency. I'm just talking about during the emergency, not during the routine situation. So let me bring you few examples, which kind of innovation. So so classification of innovation. In fact, there is 4 kind of innovation. Mission-driven innovations, when we know already the situation. And then we have enhanced, when we already know what we are expecting to do. For example, during a pandemics, we were talking about these vaccines. So vaccine was the topest priority. So that's why some enough resources was allocated for that, and within 1 year, fortunately we had the vaccine for the same disease. Although before that, sometimes vaccines for the Ebola it took 5 years. Enhanced oriented innovations, this is a situation where we know the solution, but the problem is only you don't know how to do it. For example, infection prevention. For infection prevention, there was different kind of innovation. And adaptive innovations, when we were adopting some local some of the challenges in the area. Anticipatory innovations, when we don't understand situation, what to do to control the situation. So this 4 different kind of innovations, what some have, respected, and there was result of the innovation. And let me bring you some of it. Adaptive and enhanced oriented innovation. We also have drive-through test centers when people were just moving from those high-risk district or high-risk villages. So people, when they were coming, to the main cities, so there was a testing centers we were testing. Walk-through test centers when people were even walking, coming, from the high-risk area, there was test centers they were also trying to test. And then COVID-19 hunting team. This is very important, and I was involved in that one team in Afghanistan. So what we were doing in Afghanistan, we assign, team of 4 or 5 people. So ambulance, and then in ambulance we had the doctors, we have lab technicians, we had also nurse, and we had also vaccinators. So they were going visiting that high-risk district. When they were finding, any positive cases in the area, so how they recognize that positive test, because they were using, the rapid test. So in the rapid test, when they were finding, some of these cases, they were trying to isolate them. But in some other area, when they also had a problem with the testing, so test was not enough, what they were doing, they were taking, the sample, people with the high risk, they were trying to collect them, to bring them in ambulance to the health facility. People with mild signs and symptoms, we were taking their sample and we were giving them kind of, information, so what kind of preventive measure they apply. We were also distributing soup, sanitizers, and we also give them some masks, and we tell them for 14 days they should be isolated in a different room until they get the result. Community isolation center was also applied, and that was implemented. So these are the innovations, the mission-driven innovations. iReferral, we were using this one for the referral of the cases. COVID-19 eliminators, we were also using COVID-19 eliminator for case tracing, and also for the home-based healthcare treatment result. And then we also have the wristband also. In this bound was using also to make sure that when some people are positive, especially coming from different countries, they were putting in a specific area, and that wristband was also connected, with the ITs. Just we were trying to make sure that these people are staying, when they are coming, especially from other areas, for 14 days when they were positive. And then there was vaccine as well. And apart from that, there was also local innovation. For example, in Pakistan, in Afghanistan, we also have, this ventilator was also made, by the students, by the professor at the university. So everybody was trying, to bring some kind of solution, to tackle, this problems. So I'm not talking a lot about this one, because this is linked with the innovations. But if there is any question, I will cover that ones in the Q&A session. So we use, different innovation to trust people, to track their symptoms, and also to link them also with the health facilities, with the clinic. So what we can take, from what kind of message we can take from today's discussion? Well, we need public partnership and global cooperations need to be strengthened, because what WHO is now saying, Dr. Tedros, WHO General Director, that nobody is safe until everyone is safe. In order to save everyone, we need to promote, this vaccine supply also to different parts of the countries. Health system need more investment in the existing health system. Unfortunately, in different parts of the world is not in a position to respond to the local need. Evidence-based decisions, scientific research need to be strengthened, and also we should also do the advocacy for the research findings, because many people, unfortunately, in developing countries, even the people in the leadership level, they are not reading, sometimes, those assessment report. For example, I was discussing, with the lab director of in one of these country in the region. I asked them, have you read, the report of the Global Fund? Because Global Fund is also providing, technical support, and they are regularly doing, the assessment of the lab capacity. So the lab capacity was not strong, So I asked them, have you read that report? What they recommended 3 years back about the preparations. So unfortunately, that was not like many people are just ignoring that one. That need to be strengthened. Universal health coverage, global health security index. Now people with the limited resources, sometimes they are confused whether to allocate, more budget for universal health coverage or Global Health Security Index, but both of this need to be developed in a parallel way, because if we don't have preparation for emergency, then many people will die from the pandemics. If we don't have universal health coverage, many people will die from those routine diseases. Now, the last thing, which is very important now, global health leaders, now the leaders in the world, they know the values of the public health, how important is that now. But it will depend on us, on the public health experts and professionals, how to get their support and practice, because everybody is ready to help them, but putting all those in trust and practice will be a question mark for us, how to make it. Ebola vaccine was developed in 5 years. COVID-19 vaccine was in 1 year. And then it means if the global leaders and public health leaders, scientists, everybody try to remove, some of those hierarchy, maybe unnecessary, administrative process, we will be able also to bring, the durations of developing vaccines in a shorter, because what COVID-19 also teaches, vaccines development process teaches us now. I think this is all, and thank you very much for staying with us. If there is any questions, I will be happy to take the question.
Haqmal, thank you for your exciting presentation. I think this was a true global health in action. We are very used to listening to science that goes on in the laboratory or in informatics space, but this is truly sort of work from the real ground level that you and your team have done, and you've cited relevant examples as well. There are a couple of questions that have come through in chat, and I'm going to read those first. And if there's any time left, then I'll ask my question as well. So there's a question from a gift, Himbisive, and the question is, was any analysis done comparing COVID-19 specific deaths to total deaths from other cases? And is there any possibility that a refocus on COVID-19 could have led to ignoring other diseases and hence causing deaths that would have been otherwise avoided? Any comment, Haqmal?
Yeah, very important question. As I mentioned in the beginning, in fact, for the research and study, minimum resources were allocated. Like for during COVID-19, only 3% of the resources were allocated for the research in the field, while for the Ebola, 17% of the resources, even in a smaller part of the world, because Ebola was not worldwide. What we have learned for the first, I think we don't have the evidence. For the second part of the question, we learned many things from the COVID-19 response. So in terms of operations, in terms of trainings, in terms of preparations, so these all will also help us in the futures when we are developing any proposals to spend enough resources also for the maintenance of some of the projects. For example, some of the projects that are applied also implementing in those areas, we don't have their effect in long term, because that is not somehow linked with the program. So most of the project that we are designing and we applied during the COVID-19, we found out if it is not linked with the program, so we may not be able, to see their benefit in long term.
Okay, thanks, Haqmal. And the next question is from Pankaj Burman. And the question is, how did your team manage testing with low testing infrastructure, with low capacity testing infrastructure? What were the major strategy that you had to identify positive cases when you had low testing capacity?
Very important one. So what we have done, this COVID-19 Eliminators, one of the apps that I just presented very quickly as one of the innovations. So this helped us for the case tracing, and also because we were also using to efficiently use, the test, because we had limited capacity there. But we were trying to find those for example, if one is positive, with how many people they were in contact. So when we train people also in the ground, when we apply this COVID-19 eliminator, it helps us in different way to find those people. Even if some people were like suspicious, we give them recommendation of 14 days. So we were trying to use, the test resources for the test for those people that they are in high risk. So clinical definition was also used in order to manage, the minimum testing capacity. So clinical definition was applied.
So that's interesting. Clinic and definition, along with the ground reality, was used. The other strategy that's used is pooling of samples for tests, and then only going for individual tests if any of the pools comes out as positive.
Yes.
Then there is another question from Juma Bakvirani. And the question is, cases have been reported in some countries around the corruption by leaders of the National Task Force managing COVID. Did you see anything such in your experience in South Asia? And if so, how was that managed?
Unfortunately, because of the poor governance in some part of the regions, so some people, they talk, they misuse the resources. They under-report some of the cases. In some cases, they over-report to misuse, the resources. And so there was several examples, unfortunately, several examples of corruption. Even, the ventilators was also misused somehow. Even the foods that was allocated also for the, to use it also in the hospitals when people were hospitalized. So we also got some miscalculation, that one. So miscalculation, misuse of the resources, unfortunately. Even in the procurement process, we found, some poor quality things were used, and then reported, high quality resources were used, like many reported for high quality, and in actual way we found very poor quality items and equipment in the ground. Unfortunately, there was several examples.
Thanks, Haqmal. I have a question around preparedness. You talked a lot about putting an effort to build resource and have preparedness. How do you tackle the concerns, coming from countries like India that are seeing, unexpected flattening of the curve without much intervention, when economy has been opened since June, and we are seeing virtually zero deaths, very little hospitalization because of COVID, and very few cases. And this is sort of going against the hypothesis that all the countries are now working on and putting together those preparedness setups under their health ministries. How do you respond to those?
I think I will also give two examples from other countries as well. It was similar situation. My understanding is probably still there is a problem with the reporting, because many people in South Asia and most of this country, we are not issuing, the death certificate. So when people are dying in their villages, especially in remote area, so nobody knows whether that is associated with the COVID-19 or not associated with COVID-19. I think maybe the problem is also with the reporting, and then poor collaborations between community and also the health facility. So in clinic, in hospital, you will see it is not properly used, like maybe not overutilized, but in the community, there is a big problem. So I think maybe in some area, you will also have some example of herd immunity. Probably there will be, if there is very limited of cases. And then there will be problem also with the reporting. And so this is the two thought that I have in my mind, because this is something that I also saw it also as a witness also in the area.
Okay, I think we've run out of time. Haqmal, thank you so much for your presentation. There is one more question, but from Pankaj, but it seems he would get in touch with you separately as well for your slides. Thank you once again for joining, everybody, and I hope you enjoyed the session. And thank you, Haqmal, for your presentation.
Thank you very much. Thank you. Pleasure having all of you.